Thank you for the opportunity to present the impact of standardization on bariatric surgery in Ontario, Canada. Do I use the mouse? Oh, I see, sorry. I have no disclosures. Ontario is the largest province in Canada, comprising almost 40% of the Canadian population. Prior to 2010, patients seeking bariatric surgery were referred in a haphazard manner, and many traveled to the neighboring province of Quebec or to the USA to obtain surgery. In 2010, the Ontario Bariatric Network, or the OBN, was created to coordinate a standardized structure and system for the administration of bariatric surgery in the province of Ontario. This network is a centralized government-funded agency that provides all bariatric surgery in Ontario. The initiatives of the OBN include a centralized referral system that allocates patients based upon their geographic location and wait times at their closest bariatric centers. The system is now online, which increases access and efficiency for referring physicians. Number two, the establishment of bariatric centers of excellence with multidisciplinary teams, experienced surgeons, and minimum requirements including ICU availability, postoperative oximetry beds, and minimum 120 bariatric cases per site per year. And these are the only surgical centers authorized by the Ministry of Health to perform bariatric surgery for the purpose of weight loss in Ontario. Number three, program standardization, which includes recommendations for perioperative, and postoperative care, which are evidence-based. Patients have an intensive 5-year follow-up schedule, which includes regular meetings with nurse practitioners and dietitians, and there's also procedural guidelines which recommend roux-en-y gastric bypass for the majority of our patients. Number four, we have a prospectively gathered registry database for research and quality care. And finally, strategic and operational quality care initiatives, which provide focused institutional and surgeon feedback about their procedures. The program has evolved with time, and implementation of initiatives have occurred on yearly cycles. The system program standardization was essentially completed as of 2013. The objectives of a study was to determine if standardization has shown any measurable effect on 3-month postoperative complication rate, 30-day mortality, and to examine long-term clinical outcomes, including % weight loss and regression of comorbidities. We performed a retrospective cohort study of the prospectively gathered data contained within the Ontario Bariatric Registry. This was performed between April 2010 and March 2015. Patients were eligible if they were undergoing bariatric surgery during our study dates. Eligibility was based upon NIH guidelines, the ability to provide informed consent, and an age greater than 18 years old. Patients were excluded if they had current alcohol or drug dependency, a recent life-threatening cancer diagnosis, or inadequately treated psychiatric illness. We gathered the data on 30-day postoperative mortality, and we also examined 3-month postoperative complication rates, including total complication rate and subgroups of surgical and medical complications. % total weight loss was calculated for patients at 1, 2, and 3 years post-op, and regression of comorbidities was similarly calculated for diabetes, hypertension, dyslipidemia, and obstructive sleep apnea. We performed our analysis by fiscal year to reflect the degree of standardization within the program. Categorical data and continuous data were analyzed using the usual statistical tests, and we also performed a multiple logistic regression to assess factors that would affect complication rate, including degree of standardization, surgeon and hospital volume as to account for surgeon and institutional experience, and patient factors. Of the 12,000 patients undergoing OBN-administered bariatric surgery, over 8,000 patients were enrolled in the bariatric registry during our study timeline. Overall, the demographics of the patients remained stable with time, and none were significantly different. The most common type of bariatric procedure was a roux-en-y gastric bypass. This has remained relatively stable throughout the years, reflecting a standardized guideline for the selection of sleeve gastrectomy. This procedure is offered to patients with a BMI over 60, planned duodenal switch, excessive intra-abdominal adhesions at surgery, or inflammatory bowel disease. 30-day mortality was infrequent, with only 6 mortalities during the entire study period. The intraoperative complication rate improved with increasing standardization, and similarly, the 3-month overall complication rate showed a significant decrease with time and increasing standardization. These improvements were despite the expansion of the program to include 2 new sites between 2013 and 2015. The 3-month overall complication rate reflects a summative effect of subcategories of complication rates. Within the subgroups, only postoperative stricture and nutritional deficiency showed significantly different changes with standardization. The majority of complications, however, did show a trend towards decreased occurrence with time. To further analyze the effect of standardization on complication rate, we did a multiple logistic regression analysis, looking at factors that may also influence complication rate. With increasing standardization, the odds ratio of a complication did decrease. This effect was found to be significant in the year 2014-15. To control for surgeon experience and institutional experience, we did look at surgeon and hospital volume per year and considered this in a factor in our regression analysis. This was not found to be statistically significant. The long-term clinical outcomes from a study group over 3 years showed excellent regression of comorbid diseases, including hypertension, diabetes, and hyperlipidemia. There was also excellent sustained weight loss without significant regain in the 3-year post-op period that we followed these patients. The impact of standardization includes improvement in intraoperative and postoperative complication rates. The effect on mortality was not significant and death was rare. Excellent long-term weight loss and regression of obesity-related comorbidities was demonstrated in the registry database. Standardization of structure and process is associated with improvements in complication rate and excellent long-term results for bariatric patients. We conclude that standardization of structure and process, operational improvements, and quality care metrics should be encouraged in all bariatric programs. Thank you.